All right, welcome all. I'm so glad you all can join us tonight to Brain Health and Wellness. My name is Jonathan Yassani, and along with my colleague Hannah Doles, we provide care navigation in the JFSA Dementia Care Navigation Program. Our program establishes an empowering environment to help improve the quality of life of those who have dementia or are at risk of developing dementia, while helping family caregivers reduce the stress and burden that often occurs while caregiving. At JFSA, we understand the importance in working with our clients, strengths, and applying a person-centered approach, which extends throughout the multidisciplinary team of geriatricians, nurses, social workers, and geriatric psychiatrists. Hannah and I meet our clients where they are at and develop individualized care plans that help produce solutions to presenting problems, from linking persons with dementia and their families with community resources to following them with their medical management. We are their point of contact for guidance as well as a listening ear. We consider the intersectionality of one's life when creating interventions that adhere to their biopsychosocial needs and experiences. Here is Hannah and myself right here, and I think you can see that, our contact information will be towards the end. And with the presentation tonight, I do want to let you guys know that we have a question and answer icon that you guys can use throughout the presentation. We won't address any questions or comments until the end of the presentation, but please try to avoid the chat icon and we will get to your questions afterwards. We also wanted to note that JFSA is pleased to offer CEUs. It will take 30 days from the date of your application or the completion of your survey to issue the CE credit. Your CE certificate will be emailed to you at the email address you provide during registration. The email address that you use to access the webinar must be the same as the one you are providing. Entering a different or incomplete email address will prevent your CE from being issued. Our presenter tonight is Dr. Dennis Grossman. Dr. Grossman is a graduate of Case Western Reserve University School of Medicine with over 30 years experience in internal medicine. He has been on the staff of University Hospitals Bedford and Ahuja Medical Centers, Cleveland Clinic South Point, and Marymount Hospitals, Metro Health Medical Center, current medical director at JFSA, and a clinical instructor at the Case Western Reserve University School of Medicine. Dr. Grossman has served as chairman of medicine and chief of staff at UH Bedford Medical Center. He has had affiliations with several nursing homes where he followed his patients after their discharge from hospital stays. He offers continuity of care and values the personal relationships with patients by following them over time with continuous monitoring to ensure positive health outcomes. For the past 30 years, Dr. Grossman has been interested in the effects of diet on chronic Western diseases and promoted plant-based diets and macrobiotic diets. Dr. Grossman believes that they play a key component in preventing and reversing some types of diabetes, strokes, and degenerative joint disease. Without further ado, I would like to present you Dr. Dennis Grossman for his presentation today on, sorry, it's a very touchy computer.
Thank you, Jonathan, and I want to thank JFSA for giving me this opportunity. And I think also I'm not an expert in the field. I'm an internist, obviously neurologists and gerontologists see dementia patients and are far more well-versed in it, but it's been something that I've had interest in, and also I have educated myself just by preparing for some of these talks and some of the newer ideas. And the topic tonight is the what's called anatomy of dementia. And what I'm trying to do is to give people a sort of a three-dimensional framework to hang the deficits that they see in a demented person and figure out where in the brain this located and how that affects the myriad of symptoms. So it's basically an overview. I don't want you to get hung up in the details, although I'll give you the details, but what I want you to come away with is just sort of a broader understanding of how the brain works and how, when it doesn't work, we get the symptoms that we see. So, basic anatomy. If I were to break down the brain into its most simplistic parts, I would say you'd start with the cerebral cortex, which is the higher level functioning. And there's a picture in the upper right corner, which kind of goes through the different areas of the brain. And I'll go into that a little later. But the top area is the cortex, the most developed, the most recently developed in terms of our history of development. The brainstem, which is an extension of our spinal column as it comes up into the head, and it's a more primitive area with a lot of our primitive reflexes and our survival mode information. The cerebellum, which is on the backside, which really is a more primitive functional area for balance, for motor skills, things that are learned, rote, and kind of more basic. Then there's the vascular tree, which is the myriad of blood vessels that supply oxygen and nutrients to the brain. The brain is about, I believe it's 4% of the body weight, but it utilizes 20% of the oxygen. So there is a very rich vascular input because it needs all that energy to do all the work that it needs to do. And lastly, the area that I'm going to sort of spend a little more time with later is something that has been coined about 2 or 3 years ago called the lymphatic system. So you're probably familiar with the lymphatic system. This is somebody's idea of the brain's version of the glymphatic system. Now, there are lymphatic channels in the brain too, and the lymph system is the waste system, the system that carries away the products of metabolism, any toxins, any things that are broken down that we want to get rid of. The glymphatic system actually is a system that is in communication with the lymphatic system, sort of dumps into the lymphatic system, but is purely alongside all of the neurons in the brain and in all the blood vessels. So it's much more extensive. Plus, it also interchanges with the cerebral spinal fluid, which is the fluid that bathes the brain and allows certain nutrients to be there, but also takes out waste. So the glymphatic system is a combination of the cerebral spinal system and the lymphatic system. And we'll get into that a little bit at the end. So why is it important to know the areas of the brain and what's the significance? Well, we've gathered from the past, from stroke patients, from patients with brain tumors, that certain areas of dysfunction identified by locating those dysfunctional areas from the tumor or the stroke create dysfunctions in terms of a person's ability to do things, to see things, to speak, and to communicate. And different types of dementia present with different types of distinct defects and deficits. If we match these characteristic behaviors with the known areas of the brain that we've already identified from prior patients who've had strokes, who've had tumors removed, then we can kind of link those together and get an idea of, you know, what's going wrong in these dementia scenarios. So here's where you can all go to sleep or not. But so I'm going to make this as simple as possible. There are 5 areas of the brain in the cortex that we ought to know about, 4 of which are shown here. The frontal lobe, the parietal lobe, the occipital lobe, and the temporal lobe. And then there's one deep inside called the limbic lobe that I'll show you in a little bit, but you can't see it from the outside. So why are these 4 lobes important? 5 lobes, I should say. Well, in the frontal lobe, we know that that's the most advanced area that of the neocortex, and its functionality is tied into a lot of motor things, but also a lot of higher order reasoning, and it's very specific. The parietal lobe is more sensory driven. So there's actually a demarcation. You'll see something that says motor cortex and somatosensory cortex. So the brain, just like the spinal column, has a motor area and a sensory area. And on the back is the occipital lobe, and that's where we have our vision and our interpretation of what we see and the world around us. And then the temporal lobes are on the sides where your temples are. And they have a lot to do with speech and very complicated. But again, those are the 4 main ones. And then the limbic lobe, which is on the inside, which I'll go into in a little bit of detail. So frontal lobe, that frontal lobe or prefrontal cortex, what we call it, has to do with our intelligence, our judgment, our decision-making, long-term memory, personality, and also has to do with the motor function of speech. You know, we joke about adolescents and young adults. They don't mature. Their ability to make decisions, their inhibitions are not fully developed, and that's kind of true because we found that frontal lobe doesn't mature, especially in males, until about age 25. Females a little bit earlier, so their development is a little quicker. But again, we match that, and we see that there is a functionality in that frontal lobe that's really advanced. The temporal lobe, as I mentioned before, is speech. It is more so, it can be motor type of speech. There are different types of speech, and I'll go into the deficits there, but the temporal lobe also has some memory issues. The parietal lobe, again, language understanding, not the motor part of speech, but if somebody talks to you or you read something, actually having the cognition of what's going on. Also, object recognition, spatial relationships are very important that the parietal lobe functions properly. Occipital lobe, as I said, visual recognition. And then the limbic lobe. So the limbic lobe has a lot of components. I don't want to go into the details, but it is really important in terms of laying down long-term memory, but also new memories, being able to process and then allow ourselves to create long-term memories. There's also an emotional component to memories in the limbic lobe, which is tied into our emotional history, our anxieties, our depressions, things like that. Very complicated. A lot of work's being done recently with that. So let's talk about the damage to these areas. What happens? So you damage the frontal lobe. Well, you don't have good decision-making processes. Financing, cooking is not very good. Leaving stuff on the stove, being forgetful, unable to follow recipes. However, long-standing complex motor functions are spared, such as dancing, singing, playing musical instruments. You know, what's interesting is in the frontal lobe, when we talk about impaired decision-making, and I joke about teenagers, boys and girls, and developmental differences there. But we also see this in people that have addiction problems. The frontal lobe, prefrontal cortex is not functioning properly. And so you get into impaired decision-making, which is one of the hallmarks of substance use disorder. The left frontal and temporal lobe has to do with actually difficulty with understanding or finding the right word, coming up with the right word, being fluent in speech, a lot of stammering, a lot of difficulty with finishing sentences, with creating a sentence that is gives proper context, subject and verb, things like that. The temporal lobe also is very important when it's damaged in inability to recognize people and objects and name them. What's interesting is they may recognize by voice, but not by appearance, so that if somebody spoke, they would say, "Oh, that's my daughter, Hannah," or something. But if they saw the person, it wouldn't register as to who they are until they started speaking. The right parietal lobe has to do with, judging distance. I can't do the whole thing here, but difficulty with distance judging. What's interesting about the parietal lobe and the frontal lobe is more motor. The parietal lobe has to do with more understanding and concepts that have to do with the meaning of things. So not being able to understand what's going on and in conversations and things like that. And then there's the limbic globe, which is comprised of many things, a couple that are very important for us to identify. One is called the hippocampus, which is very important in terms of memory, in terms of new memories, in terms of laying down old memories. So all those are part of this. And when you get damage to the limbic globe, you get aphasia. You have the inability to speak, to understand written language. You cannot lay down any new memories. You may have hormonal dysfunction because it's tied into the hypothalamus and the thalamus, and a lot of hormones are secreted indirectly from input from the limbic globe. There may be emotional dysfunction, anger, pleasure, aggression, anxiety, all may be either deficient or overexpressed. So these are areas that we don't know specifically where in the limbic system, but we do know that all of these, when the limbic globe is damaged, may come into play. A person may be very passive, they may be very aggressive, they may be anhedonic, have no pleasure in anything. So all of these we see in damage to this area. I also mentioned there are other parts of the brain. There's a more primitive area called the brainstem and midbrain. I only mention this because of one of the forms of dementia that may affect that. So the midbrain is more movement and coordination. It gets affected in diseases like Parkinsonism. There's an area called the pons, which has to do with actually focusing, visual focusing, facial expression. And people that have damage there may get flat affects. And then when you get down to the really basal structures, the medulla, survival skills, breathing, blood flow, heart rhythm, that's when people don't survive if they have strokes or damage to those areas. So there's a dementia, there's an umbrella of dementia. And I picked 4 things only because they were probably the more prominent. There's lots of different areas under the umbrella. But if you see the first one, Alzheimer's, it's probably 60% of the cases that are seen are Alzheimer-like dementia. And the hallmark has to do with amyloid plaques, tau protein, what they call neurofibrin tangles. And I'll go into some of the symptoms, but most of it has to do with impaired memory, language, and some visual spatial problems. And then there's vascular dementia. So vascular dementia, remember, there's a huge vascular tree that feeds this brain. And damage to any of that area will cause dysfunction in the areas. And if those have to do with memory, language, affect, those people are going to appear demented. And that may be 10 to 20% of dementia cases. So there are two major types of vascular dementia, and that has to do with occlusive occlusive vascular disease, where there's a blockage and blood flow doesn't get through, and then there's death of the brain cells beyond that blood vessel. And there's hemorrhagic, where there's bleeding and there's damage from the blood, and sometimes that has to do with high blood pressure, problems with inherited blood thinning problems, clotting problems. I'm sorry. The symptoms are, there's a myriad of symptoms with vascular dementia. And the reason for that is it depends on what blood vessel, in what location, and it could affect judgment, it could affect motor skills, sensory skills. It could mimic Alzheimer's disease. It just depends on where that blood vessel is that's been damaged. Frontotemporal dementia, probably about 10%. So frontotemporal means it affects the frontotemporal areas of the brain. And usually that has to do with some difficulty with the decision making, sometimes personality changes. Obviously, there are some issues with language and difficulty with sort of caring for themselves and not being able to initiate things. And then lastly, there's something called Lewy Body Dementia, which in many cases may be an offshoot or an end result of a Parkinsonian type of course, although not always. Lewy body dementias refers to these Lewy bodies that we see in an area of the brain that's actually in a more primitive area of the brain called the substantia nigra. The only reason why it's called the substantia nigra because it appears darker because of the dopamine producing cells that are there that stain dark. And there's a loss of these cells over time. And what happens is there's a protein that's deposited there on the nerve cells, and people will get, they'll get impaired thinking, some motor skills. They may have worsening of Parkinsonian type of picture, shuffle gait, falling, stiffness, and also hallucinations for some reason, visual, maybe auditory. There's a lot of other dementias, but I just, I'm throwing out 4 of the major ones just so that we have an idea of, where in terms of damage to the brain structure, these dementias fall. And as I mentioned before, Alzheimer's affects mainly the cerebral cortex, especially the midfrontal area of the brain, and also the limbic globe. And the part of the limbic globe that Alzheimer's seems to affect is what I mentioned before, the hippocampus. And I'll come back to that. It's kind of an interesting situation. In Alzheimer's, there is a decreased size of the brain. You lose brain cells. You also get these proteins that are deposited, beta amyloid, tau, that appear to be toxic when they accumulate. Frontotemporal, again, as I said, frontal lobe, temporal lobes, and their various fortunes. Vascular dementia, again, affecting all areas of the brain depending on what blood vessel is damaged. And then again, Lewy body dementia, concentrated more in the brainstem, more of a primitive area. So what do we look for when we assess a neurologic deficit? How does a physician address a person that is brought in for questionable neurologic changes? Well, you look at the motor function. You do strength testing. You watch how people walk. You look at their gait. You look at their balance. You do a sensory exam. You figure out if they've got deficits in pain, light touch, in proprioception. Do they know with their eyes closed that you're moving their toe up or down? You test their reflexes, and that a lot of times has to do with their spinal column and their peripheral nerves. You check their cranial nerves, which are the nerves that exit through parts of the cranium, and there are 12 of them, and they're very specific, and they have to do with smell, sight, hearing, and motor function in the upper part of the body. And then there's a mental status examination, and that's where we assess higher function, and that's where we get into the nitty-gritty about, is this person have a neurologic deficit that has to do primarily with their thought processes and with their ability to function on a certain level. And it's kind of interesting because, you know, there's a fine line between dementia in some cases and psychiatric problems, depression, anxiety, things like that. So, but we're not going to delve into that area just to say that this is what we do when we assess somebody. How do you approach the functional aspects of the brain? Well, the physician looks at the level of consciousness, you know, how alert and how awake is that person? How oriented is the person to person, place, and thing? Their language, speech, writing, reading. New memories. Can they recall 3 objects? Which I have difficulty with, but anyway, they always do the same 3 objects and test your memory, your short-term memory. Remote memory, what'd you have for breakfast this morning, or, you know, things like, well, who was elected president last week? Calculations, you give them some calculations. Abstractions, similes. Why is an orange like an apple? Gee, I don't know. Well, they're both round. Okay. So, and judgment, you give them things to make a judgment upon. And from those 8 things, you kind of get a sense of where the person's mental state is and their ability to function in society. Something that's interesting, I'll just throw this out, and again, this is more sort of an oddity, but there's something called the 8 A's of dementia. So the first A is called I can't pronounce it. Anosognosia. Inability to pronounce the word. No, inability for someone to understand their mental condition. One of the hallmarks of mental illness is when a person doesn't realize that they're mentally ill. But also one of the hallmarks of dementia is a person doesn't realize they have deficits, mental deficits. So agnosia, inability to interpret sensations, recognize objects that are familiar. Aphasia, inability to speak properly, whether it's motor or sensory. There are 2 major types of aphasia. One's called motor, Broca's aphasia, and one's called sensory, Wernicke's aphasia. And the difference is that a person with Broca's aphasia knows exactly what they want to say, understands the language, but the words don't come out right. And there was a surgery that was done for people with seizures, and they would cut the corpus callosum, which was a connection between the right and left hemisphere. And they found that people that had aphasia, that had what they call Broca's motor's aphasia, which was in a certain one side of the temporal lobe, that when they cut that, they would ask him a question and tell him, is this the word you see? And they would say, no. And then they would inadvertently shake their head and they'd say yes, because they couldn't communicate verbally, but physically they knew it was wrong. So they actually would tell the other half of the brain that the correct answer, yet there was damage to that one receptive area. So anyway, it's complicated, but there's lots of different types of aphasia. Apathy, indifference to people, places, things. Apraxia, that's a misspelling on my part, APRAXIA, difficulty with movement. And it's not due to muscle problems. It is due to the brain. The muscles are fine, it's the brain that can't coordinate it. Altered perception, and some of that can be hallucinations. amnesia, of course, forgetfulness. So those are the 8 A's of dementia. Let's look at Alzheimer's. I'll get too long in this, but in Alzheimer's disease, what's interesting is that we see a decrease in the hippocampal area of the limbic globe. It shrinks. This is an area that affects new memories, recent events, especially what they call declarative memory for time and place of things that have happened. It spares the learned memories, the long-term memories initially. Later, it affects the amygdala area of the limbic globe, and that affects emotions, and that's something that many Alzheimer's patients go through, which are some emotional upheavals. And then lastly, we see a lot of cortical thinning and atrophy and a lot of beta amyloid deposition in the frontal cortex, the middle frontal cortex. This is affecting the long-term memory, judgments, problem solving, orientation. This is progression, 1, 2, 3. So depending on the stages that the person is in. Vascular dementia, quite different. There are different types of vascular disorders. We call them occlusive or hemorrhagic, as I spoke before. One is blockage, the other is bleeding. We have something called lacunar infarcts, lacunar strokes. These are small peripheral blood vessels out at the periphery, and they tend to affect the executive function, the more complex decision-making functions, but memory itself is quite spared. So person doesn't know how to initiate things or how to follow through, but memory is still okay. And then there are what we call the medium and large vessel diseases that have been blocked off. And depending on the location, you could get all sorts of issues such as aphasia, apraxia, meaning difficulty with speech, difficulty with walking, motor things, thalamic infarcts, which is an area of the limbic system, will lead to a picture just like Alzheimer's, so you couldn't even tell the difference. So, Lewy body dementia. Kind of interesting in that Lewy body dementia affects the neocortex, the higher areas of the brain, but it also affects the lower areas, which is the motor dysfunction we see with Parkinson's disease in the brainstem. There is no evidence of loss of speech or difficulty with words or even severe memory loss. Those are intact, but there is an inability to read facial expressions, to react. And there's also, in many cases, impaired vision, spatial perception, and visual hallucinations may be the hallmark of it. Frontotemporal dementia. Biggest thing has to do with inhibition, socially inappropriate. Again, this is the front part of the brain, higher functioning, inappropriate urinating or passing gas in public, inappropriate kissing, social behaviors, and also there could be apathy, loss of empathy, passivity in conversation, inability to actually converse in a meaningful way. Hyperorality, meaning pleasure, excess pleasure in carbohydrate cravings, sweets, binging, alcohol, tobacco, and compulsivity, perseveration, ritualistic behaviors, rigidity in terms of their routines. So I mentioned those 4 dementias. I guess I went ahead too quickly. I mentioned those 4 dementias to give you an idea of where structurally the damage may be. There's a lot of overlap, but it gives you an idea of different diseases create damage in different areas. Now I want to move on at the end here to kind of throw in a wrench, and that happens to be the lymphatic system and something that has to do with the development of dementia. So the lymphatic system, as I said before, is kind of like the lymphatic system that incorporates fluid around the blood vessels and the nerve structures, the nerve cells in the brain. And it's utilized for cleansing and getting rid of toxins. And it is an integral part of the health of the brain. It's a network we call glial cells, hence lymphatic. Glial cells are not the brain cells, the neuron cells, but they're adjacent to the neuronal cells. And their function is to clear waste from the central nervous system, and it's primarily during sleep cycles. So here's where the interesting part, or what interested me when I was reading about this. These glial cells form channels which collect cerebral spinal fluid, CSF, and these circulating CSF carries away the waste products. So amyloid beta is a protein that accumulates in certain areas of the brain in Alzheimer's patients. And amyloid beta has been shown to block the ability of the glial cells to transport cerebral spinal fluid away from the nerve cells and detoxify the brain. So it kind of gums up the works. Although Alzheimer's disease is primarily a disease of memory loss, it has not been shown to be present in the hippocampal area of the brain, which is responsible for short-term memory. So quite interesting. How does that happen? How can we explain that? And here's where the interesting part is. The key to understanding how amyloid beta leads to Alzheimer's dementia in a person is tied into their ability to have non-REM sleep. So non-REM sleep, well, we know what REM sleep, it's called rapid eye movement sleep, and it is a deep sleep. It's a sleep in which we dream in. But non-REM sleep is a deeper sleep. And I'm not sure that we dream in it. I'm not sure they know that, but we know that there's a significant reason for us having non-REM sleep, and that has to do with the cleaning of the brain. Amyloid does not affect the memory areas of the brain, meaning the hippocampal areas, but it does accumulate in the middle part of the frontal regions of the brain, so the frontal lobe. And these frontal lobe regions of the brain, specifically the mid-frontal area of the brain, controls what we call non-REM sleep. The amount of non-REM sleep, the ability to have non-REM sleep is impaired when beta amyloid accumulates in the middle part of the frontal region of the brain. So that's part of the key. So you've got these stages of sleep. And if I haven't put you through all four stages right now, bear with me. Stage 1, light sleep. Stage 2, light sleep, I don't know, and relaxation. But stage sleep is that REM sleep. And stage 4 is actually non-REM sleep. I'm not sure. Stage 3 is deep sleep. That's really non-REM sleep. Stage 4 is REM sleep. So non-REM sleep is actually the deepest state sleep. During non-REM sleep, the glial cells shrink by about 60%. So those are those helper cells that allows increased cerebral spinal fluid flushing of the neuronal cell debris. This improves the cleansing effect by 10 to 20 times, 10 to 20 fold. So imagine that. It's kind of like a super flush. Non-REM sleep originates in the mid-frontal region of the cerebral cortex. In other words, it is initiated there. This is precisely where the majority of amyloid beta is found in Alzheimer's disease. In Alzheimer's disease, the amyloid beta and the tau protein are not removed by the lymphatic system. So without this non-REM sleep, you have toxic levels of amyloid. Oops, battery's running low. Okay. Non-REM sleep. We'll get through this. And oops, back. Okay. So in addition to that, in addition to the fact that the non-REM sleep affects that mid portion of the frontal lobe, there's something else that happens. In Alzheimer's disease, we see that the hippocampal area, although it doesn't accumulate beta amyloid, it shrinks. It shrinks remarkably. And so that there is less and less ability to make new memories. And with the added burden of not getting rid of the toxins because you're not cleaning out the beta amyloid, you have a double whammy. Here's an interesting fact about the hippocampus. Why do we know that the hippocampus is so important in memory? Well, they did a study on New York City cab drivers. What they found was that if you took a new cab driver and you did an MRI on that cab driver, you could map out how big their hippocampus was. If you redid that MRI 6 months later, you'd see it increase in size. And then if you did it 2 or 3 years later, you'd see it increase in size even more. So this did not happen with bus drivers. This did not happen with any other form of transportation drivers or Uber drivers. And here's the I guess the clinker. Cab drivers didn't use any apps. They just memorized and learned all the ways, the routes of the city and all the intricacies and all the things that happened on a daily basis that changed so that they could route themselves. So they actually exercised and increased the size of their hippocampus, and it was in their memory cells. Interesting. So if you look at it here, you see that deep sleep deprivation shuts down the memory inbox in the hippocampus. Damaging the hippocampus causes amnesia or inability to make new memories. Non-REM sleep deprivation is the equivalent of inactivating the hippocampus. Thus, lack of non-REM sleep contributes to the development and progression of Alzheimer's disease. Sleep apnea, insomnia, lack of adequate sleep can contribute to cognitive decline. Alzheimer's patients are known to have inadequate sleep. The reverse has also been supported in numerous studies. Margaret Thatcher and Ronald Reagan boasted about getting by on 4 to 5 hours of sleep. And do you know what? Donald Trump also boasts about 4 to 5 hours of sleep. So I'm not saying that there's a parallel there, but maybe there is. So I just want to throw this out. Some of this information was in a book that I read called Why We Sleep. And I think it's fascinating. It has a couple chapters on dementia in there. And if you have the time or interest, get out of your library and look into it. And that's all I have. And I'm opening it up to questions. And thank you for being with me this evening.
Wow, that was amazing. Sleep, yeah, loads of great information. So we will go ahead and take some questions. I'm sure there's some questions out there. That was amazing. Lots to think about. So one question, does Alzheimer's disease always start in that frontal section of the brain?
Well, I think it's shown that the beta amyloid accumulation is on the frontal area where most of it is. So I would say the answer is probably yes. It's in that area. Later on, though, it affects, like I said, more of the limbic system, more of the other areas. Mostly more complex.
Yeah, and then eventually the like more primitive, like the brainstem. Yeah.
But mostly the limbic system, which is affects a myriad of things because it's hooked into our hormonal system, our hypothalamus, we secrete enzymes, we secrete things, hormones and enzymes.
Where are we at with the treatment of Alzheimer's?
Well, that's a good question. So I think where we're at, for the longest time, we've tried to figure out how to minimize the effect of beta amyloid. I think now things are turning, and I believe it is because that seemed to be a dead end. The medications that we have that decrease supposedly the amount of beta amyloid have had very minor impact on the disease, maybe lessen the progression, maybe prolong the time of onset, but there has been no real impact. Now I think they're trying to figure out other areas that they can focus on other than getting rid of beta amyloid. And some of that having to do with maybe inhibiting the production of it, but also looking at improving the functionality, improving the detoxification. There are some studies that are looking at how does sleep help? Does non-REM sleep and getting people into non-REM sleep, does that improve the detoxification and the improvement in terms of functionality? And that's one of the areas that they're researching. But there's been no breakthrough in terms of medication, if that's what you're asking. So there's I think a shift in terms of where they're trying to focus on, away from the medications that most of us have heard of that are tried and true, but they don't work very well. So, and they don't last very long. That's the unfortunate part.
What part
I'm not sure. My neuroanatomy is not that good. So that's a good one.
yeah, do you think it's like part of like
More permanent.
She's
talking to you.
That's a good question.
Yeah, I don't know.
It stumped us.
Yeah.
Okay. There's some common medications known to interfere with REM sleep.
Oh, yes, absolutely. So you need to actually be aware of that.
And there'll be some, so when you see a side effect that's insomnia, which is a common side effect of a lot of medications, you need to be aware that that may affect non-REM sleep. I don't know the specifics, but there are a lot of medications like that. So look at the list of side effects, talk to a doctor, especially if you're having issues with sleeping, can't get to sleep, can't stay asleep. And the other area that we encourage people to delve into is sleep apnea, inability to have the proper type of sleep.
Can you explain the difference between Parkinson's disease and Parkinsonium or Parkinsonisms?
Parkinsonism, it refers to the movement disorder, which is characterized by a halting gait, short steps, difficulty starting a movement, and then pulling yourself forward and having difficulty stopping, rigidity in terms of the joints, some what we call cogwheeling, where there's ratchet type of movement, some shaking, pill rolling. These are the Parkinsonian manifestations. Parkinsonism is the disease of Parkinsonism has to do with the destruction of the substantia nigra in the brain and the inability to produce the dopamine proper for fluid movement, things like that. So one is just a term that expresses the physicality. The other is more showing the damage area and what the cause of the physical changes are.
You couldn't tell we're on a computer tonight. So bear with us. It's very, believe it or not, it's quite different. So I'm just going through here to make sure we're not missing any questions. But if you guys do come up with any questions here in a little bit and we don't get to them, please reach out to me and I will contact Grossman and gets those questions answered for you. Okay.
And there was one thing I did want to say. It would be really good if people sent in what topics they wanted future talks to cover, because I'm running out of good ideas. Anyway, no, I think it's really something that your input is important to finding things that will serve the public. Okay?
Thank you. So our slides stopped working, but I do want to let you all know that we're glad you joined us tonight, and please go ahead and complete those surveys. They're really helpful for us to understand how you interpret our presentations, if you guys are looking for different kinds of topics like Dr. Grossman mentioned, and how we can improve them. And it is mandatory to complete those surveys, as mentioned earlier, to get your CEUs, which can take 3 days. Again, if you guys have any questions, my contact information is here, as well as Nicole's and Hannah's. So with our dementia care navigation program, we work with 2 geriatricians that are part of this program. They're amazing. They work one-on-one with our clients and caregivers, and they're part of our team, which means they help create care plans along with the patient navigator. And we're able to closely follow them and easily communicate with these doctors. If anything comes up, it's very easy to get in touch and create those plans and put things in order. And then our other instructor, Leanne Stuver, here's her contact information, as well as Nicole's. And she's the one you want to contact for future registration. Our additional resources, we have our Savvy Caregiver Workshops program. That's for family caregivers. We have our dementia support group twice a month. And of course, our care navigation program, along with the respite that's included with it, and our brain health and wellness series. Our upcoming live webinar for brain health and wellness is Your Friends Can Improve Your Brain Health, presented by Leanne Stuver. And that's going to be Thursday, November 18th at 6:30 to 7:30. For more information or help with registering, please contact Nicole Herbert Hale. Her number is 216-903-1189. And thank you so much for joining us tonight. I hope you have a good evening.